IVM.
If you look at Indian healthcare, eye care looks like a bit of an outlier. Like with other areas of healthcare, the private sector dominates, but there's a certain history and a certain legacy of affordable eye care that survives. Dr. Gullapalli N Rao, founder of the LV Prasad Eye Institute in Hyderabad, joins me today to talk about human vision, eye health, and healthcare on the Pragati Podcast. And dear listener, in case you're tuning in for the first time or after a few weeks, the Pragati Podcast is experimenting with rich interactive episodes that go beyond the audio and the conversation. You can check out related links as we discuss specific ideas on the show. You can take polls while listening, and you can do all this after you're done listening as well. Tune into this episode from your browser at tinyurl.com/pragati147 or via the IVM Android app or the Adori iOS app for the full experience. Welcome to the Pragati Podcast, a weekly talk show on public policy, economics, and international relations. We take a step back from noisy political debates and dive into rich conversations on India and the world. I am your host, Pavan Srinath. We'll start this episode's conversation after a short break.
Hey everybody, welcome to another great week on the IVM Podcast Network. If you're not following us on social media, please do. We're IVM Podcast on Twitter, Facebook, and Instagram. We'd like to thank our sponsors this week, Paytm Money. So, a great week of shows behind us and hope that you've been catching up on as much of it as you can. We had Abhishek Bachchan on Football Shitball. Yeah, let me say that again. Abhishek Bachchan was on Football Shitball. Did I mention Abhishek Bachchan was on Football Shitball? That was a fun episode. You should definitely check that out. Really, really deep conversation about cricket and things like that. We had Vikram Kochar on Cyrus Says, talking about the platforms and stuff like what's going on over there. On the note, Maruk had spoken to Sanjay Jha, which was again a really, really interesting conversation. On Edges and Sledges, the guys are having an interesting conversation about, well, you know, what are our favorite formats of cricket and things like that. So it's just really been a really, really awesome week on the network, and please do check things out. And with that, let's get you back to your show.
Hi, Dr. Rao. Welcome to the Pragati Podcast. It's an absolute pleasure to have you on the show.
Thank you.
We are here today to talk about eye care, ophthalmology in India, affordable healthcare for all, as well as your personal role in it in the ophthalmology space. But before we speak about any of that, could you tell us a little more about the wonder that is the human eye? And I'm asking this because when I was in graduate school, I had a lot of my friends who were in the biosciences who would sometimes take an entire course on the eye and its evolution. And they spoke about how just tracing the evolution of one organ like the eye can tell us so much about life, biology, the world, and so much more.
Eye is often called as the microcosm of the body. The entire developmental process, it involves all the basic primordial layers that are involved in the evolution of the entire human body. That's why whenever you think of eye, it has all the elements. Of course, it's essentially, if you might want to call it, part of the brain, an extension of the brain. It's of what we call neuroectodermal origin, and then that's how the whole entire eye is developed. So that's the basic embryology of the eye. It starts actually appearing in embryonic form around 4 weeks of embryonic age, and then slowly evolves. And the entire growth of the eye continues up to 2 years post-birth of any individual. So if you are looking at biologically, genetically, embryologically, in all respects, it is something like a real microcosm of the rest of the body. Most of the problems that affect the rest of the body, that's why also can impact the eye and cause problems in the eye.
And vision is perhaps the most important and the most primal of our senses just to navigate the world around us, right? Because the world exists in these 3 dimensions and through time, and a loss of vision can be one of the most impairing things that can happen to any of us.
That's right. I think the sense of vision is very important for functioning, although in the present day world, even those people who are visually impaired, we have tools and the training mechanisms, systems that can make them function almost as close to normal as possible. Many of them can work like normal sighted people.
I hope to talk about more of that a little later in this episode as well.
Yeah,
And it's interesting that the eye, and when we look at it in our textbook diagrams and elsewhere, almost looks artificially made, right? I mean, there's a lens which to us feels like something which we can only make out of glass or a transparent substance. Even like making lenses out of plastic is not a technology that is very old, probably
yeah,
just a few decades.
yeah,
And in fact, I remember, I think one of the reasons why people teach evolution also through the eye is because the eye is so complex that somebody can say that this needed a supreme creator, and life had to be created artificially for something as complex as the eye to come about. But evolution actually has traced how from simple cells in ancient organisms which could just detect if light was there or not there,
yeah.
all the way up to the complex functionality of the human eye, the evolution can be traced quite well.
Yeah, if you look at it, eye is like a camera. It has a lens system in the front of the eye, and the film, the retina, is in the back of the eye. So the cornea and the lens in the human eye act as the lens systems, and together they contribute 58 diopters. And then the back of the eye, the retina, is the one which acts like a film that captures the images and then sends the image impulses through the optic nerve to the brain where it is processed.
So, Dr. Rao, maybe I want to start with what is the most common challenge we see with our eye. Even say if we compare it to a camera, there can be challenges between how the lens focuses and where the film or the retina is, right? And I'm someone who from a very young age had hypometropia, as opposed to most kids, I think, who grow up, they're more likely to have myopia. So can you tell us a little about these most common challenges that we have with the eye growing up and as adults, whereby we start wearing glasses for a variety of reasons?
Yeah, there are two major problems confronting the world now in terms of vision impairment. One is what we call myopia or short-sightedness. That is predicted to become a major epidemic in the next 10 to 20 years. It used to be the belief that you develop myopia at a very early age, and then by age 20, it stops progressing. No longer is that true. A number of series of articles were published from around the world that myopia progresses well into the adult age up to age 40, 45. So that combined with the myopia that we see in children, almost more than 1 billion people in the world already are affected. There is a feeling that it might end up affecting almost half the world's population in future. The other extreme in the elderly, that is usually after age 45 and much more pronounced after age 50, 55, is what we call nearsightedness. That means the ability to read or do any close work will be affected. This is because we are born with what is called accommodate to different distances to see clearly. That is gradually declines over the years. And when somebody reaches age 40, it starts declining even more. And by around 45, 50, because of the ability to accommodate, one would require artificial correction with glasses to be able to do work at near distance.
And it is for this reason, right, Dr. Rao, that I think growing up, people would call this Charlies, because you would usually turn 40 and then need reading glasses.
That's right. So this problem affects more than 1 billion people again in the world.
Wow.
So together, myopia and presbyopia constitute the biggest vision impairing challenges in the world.
So, Dr. Rao, I want to talk about myopia or nearsightedness first. Is there a reason why we are seeing more myopia in children as well as in adults, as you mentioned, now in the 20th and 21st centuries? Is the presence of screens with artificial light and so on, is this affecting our vision and its development, or is it just that we are catching it more now? that 100 years ago, most people would never get diagnosed with myopia, so we would never know if somebody was short-sighted or not. So how do we understand why this is happening?
The reason why it is coming out more prominently now, I think, is because of both the factors that you mentioned. Increasingly, people are confined to indoors more and more, particularly in the urban living. That's why between urban and rural populations, there is a significant difference in the prevalence of myopia. So those people who work outdoors, they have less prevalence of myopia. There are two reasons for it. One is when you're out there, you look at farther out all the time. You're not looking up close. The second is the light factor. So which factor is contributing to how much is still not clear. So much so in the schools in Singapore, Hong Kong, and some of the Chinese provinces, they have a mandate that every school kid has to spend a minimum of 1 hour outside the classroom during the day. The second thing that some of the Chinese provinces did is they have built classrooms with glass walls so that more and more light gets into the rooms. So these are some of the factors that people are trying to do to bring about some behavioral change. One is the light factor, second is to make people come outside and look farther out instead of constantly looking at shorter distance or on the screens, working inside.
So is the idea that because our eyes are not focusing on enough things at a distance for not just a day but years on end when we are growing up, we just lose the ability to do so itself?
Yeah, that is a factor. Yeah, that's a big factor.
Okay. This is now something that's established. Any idea about what happens through adulthood? You mentioned that now you're seeing more instances of myopia. Again, I remember reading in my class 12 biology textbooks and so on that because the human eye grows sometimes at a different speed than, say, the skull surrounding it, as we age, power of our eye can change. So is that part of the natural development process, or is something else happening that is abnormal?
Actually, normally the growth of the eye stops around, as I mentioned already, around 2 years of age.
Okay.
In myopics, the length of the eyeball becomes much longer than usual. And that's why when the light is projected onto the eye, it is coming to focus in front of the retina instead of on the retina. That's why you need a lens to converge those light rays onto the retina so that the person can actually see. Diverge the rays to fall on the retina, not converge.
Thank you for this little precursor on the biology of the eye, and we'll keep coming back to various aspects of this. I want to switch gears and ask you a little bit about, you had a very successful practice in ophthalmology in the United States in the 70s and the 80s. And you returned to India, I think, in 80s and started the LV Prasad Eye Institute, if I'm not mistaken, in 1986 or so. And I have been a beneficiary of similar efforts because I grew up in the 1990s. I was born in the 80s. And for me, again, as a person living in a large urban city in India, I had good access to eye care and eye health care in my adolescence. And I think that helped me significantly. I could get glasses quite early on. I could start correcting my vision. So could you give us a picture of what eye care was like in India in the 80s and 70s, and how did that compare with where you were practicing in the United States?
If you want to look at the standard of eye care across the entire country, it was certainly suboptimal because we were not rapid enough in the introduction of new knowledge and technologies in the practice of ophthalmology in the country at that time. We were not allowed to import equipment freely. There was a lot of customs duties and all that. Hardly anybody has any eye care diagnostic or equipment to treat the diseases in those days in their clinics or in the hospitals in India. So the standard of ophthalmic care in those days was certainly suboptimal compared to what was happening in the West or in the US. For example, every day in the clinic, when you go to a clinic, you probably were examined by an instrument called slit lamp, where you put your chin on something and then the doctor sees from the other side through a microscope.
And there's a bright light that is shined on my eye.
That's right. So that was a routine thing in the US. Every single patient is seen on it when they come for an eye checkup.
Okay.
And in India, hardly anybody was using those slit lamps in the 80s. And second thing was, in America, most of the surgery by mid-70s was done using an operating microscope. But even in the mid-80s in India, very few were using operating microscopes. So these were the kinds of, just a few examples of the differences. Because we just didn't have the infrastructure. And the second major difficulty, and that actually in some sense continues to haunt us even today, is inadequate number of well-trained faculty in our training programs.
Absolutely, Dr. Rao. And I asked you some earlier questions about what we could consider primary eye care, right? Where it's about power, about corrective lenses and wearing glasses to correct for, myopia or hypermetropia and so on.
Right.
But beyond that, I've also grown up hearing so many stories of legendary doctors conducting not just thousands, but tens of thousands and lakhs of surgeries, right? And the most common are usually cataract surgeries, I think surgeries to relieve pressure in glaucoma situations and so on. So could you tell us a little bit about the surgical aspects of that are prevalent in eye care? What are the standard and the very common challenges and disorder and disease burdens that you see in eye care?
I think the number one problem that causes blindness in India continues to be cataract. It used to be nearly 70% of all causes. Now it is about 50% because of two reasons.
But even today it's that high.
Yeah, it's because of a number of factors again. And this was the problem. There's a huge backlog of several millions. In the early 90s, it was about close to 12 to 14 million cataracts backlog number. That was the volume that we had, the burden of cataract blindness. And it was almost 25% of the global burden. India had the dubious distinction of number one in this area in the world. Because there wasn't enough infrastructure at that time, there weren't enough well-trained ophthalmologists to tackle the entire magnitude of the problem. The innovation in those days was these massive eye camps that were conducted by many of the people in different parts of India. And that's where thousands of operations are done in each day. While they have done their bit at the time they were needed, they also left behind a trail of problems which nobody really addressed. In fact, we were the first ones in the mid-90s. We conducted a study called Andhra Pradesh Eye Disease Study to look at the outcomes of past cataract surgical interventions. From that, it became clear that a large percentage of the people who have had cataract surgery in the past are ended up being blind. In the rural areas where we did this study, it ranged between 30 to 43%, ending up being blind.
Wow.
And in the city of Hyderabad, it was almost 25%. So a number of people tried to provide care, provide cataract surgery, but under less than optimal conditions. A number of factors contributed to that poor results. But I think once those papers came out, I think everybody woke up, and that led to a large-scale, multi-country study conducted by the World Health Organization. And in all those countries, the Nepal, Egypt, Chile, all these countries, it was very similar. So that's when people began to look at the qualitative aspects of cataract surgery and paying more attention to it. The Indian government approached the World Bank for a low-interest loan, got the support from the World Bank, and started a massive cataract program in the country. that turned around both the quality of surgery as well as ability to address large numbers of cataract surgical patients. So between 90 and 2020 now, there has been a significant progress in India. In the early 90s, we were doing about 1.5 million cataract surgeries in India. Now we do approximately 7 to 7.5 million a year in the country. And of course, now we are worried whether the COVID-19 is going to interrupt that kind of a growth and to what degree.
And Dr. Rao, you were saying that while there are 7.5 million or so surgeries happening every year, they might be up to double that number, say 15 million people every year who might be getting cataract and blindness because of cataract. Is that fair, or is the number a little lower?
We believe that the requirement to take care of both the cataract blind as well as those people who have relatively earlier cataract but cannot function normally, if we combine all that, our need may be 10 to 12 million a year.
But we are significantly closer to that mark today than we were.
That's right.
20, 30 years ago. And as India becomes an older population where people's life expectancy has become longer, the need for cataract surgery becomes even greater, right?
Yes, that's true. The aging population brings its own set of problems.
So here, Dr. Rao, maybe cataract can be a good starting point for us to think about blindness and for us to learn a little more. So could you tell us first about cataract and how this leads to blindness? Does it affect the cornea? And what other reasons can there be for partial or complete blindness? And how do you in healthcare approach such challenges?
Cataract is essentially opacity of the normal lens that we have in the eye. The normal lens in the eye is a clear lens. But when it becomes opaque, that is called cataract. So the only treatment for cataract is surgical removal of this opaque lens. And of course, in the current system, that then is replaced by an artificial, what we call intraocular lens, which compensates for the power that was originally provided for by the natural lens. That is about around plus 15 diopters. So that's what happens. So this is an aging process mostly, and a number of different other factors also contribute to the causation of cataract, but the most common is the age-related problem. So anybody above, as one ages, the chances of developing a cataract increases. And in India, typically it happens about a decade earlier than in the Caucasian population in the West.
Is that linked to nutrition and other reasons in the country?
It's linked to a variety of factors. It linked to exposure to sunlight, it linked to the environmental conditions, it linked to smoking, it linked to even the cooking oil that we use. So a variety of factors and genetics, all these contribute to it.
And what about other causes of blindness, Dr. Rao? Could you give us a sense? We are a country of 1.2 billion people, but how many people suffer from various forms of blindness? What are some of the causes? And today in 2020, which of them are at least partially addressable or curable?
So if you look at it, there are preventable causes of blindness. Under that comes the vitamin A deficiency. It used to be an infection called trachoma that was gone, fortunately. Almost maybe a few pockets may be left in northern part of India. Even vitamin A deficiency is more or less under much better control compared to the past. And then some of the traditional practices that were used in the tribal areas and all that is a thing of the past. The second is treatable conditions. The two most common treatable conditions causing vision impairment and blindness are what you mentioned, uncorrected refractive error that includes myopia and all. And the second is cataract. The significant facts about these two is both occur in every part of the world. Both occur typically in the two age groups, the children and the elderly, most commonly. And both also have very effective and cost-effective treatments already available. There's no further big time research required or anything. Good techniques, good technologies. Surgical intervention of cataract is one of the most successful surgical intervention anywhere in the human body. And the surgical technique is a very cost-effective thing. Similarly, for myopia kind of thing, all that you need is a pair of glasses in most cases. So from that perspective, these are the two easily treatable conditions, and they together constitute 65 to 70% of the problem. And then they don't have to be taken care of in urban tertiary care centers. They can all be tackled. All the myopia, refractive error, most of it should be able to handle at the primary level of healthcare. Cataract can be taken care of at the secondary levels, at the district level. So these are two big things. The other problems are corneal blindness because of injuries, infections, etc. And that also is preventable, most of it, the infections and the injuries. And if it is not prevented and if it leaves a scar on the cornea, the only way to rehabilitate that person visually is by corneal transplantation. So that's a major cause in India. India again has the largest magnitude of corneal blindness in the world. And the next is glaucoma, a silent disease. One would not know easily. The symptoms are not very clear. So anybody with family history of glaucoma, diabetes, etc., after age 40 should make sure that they get frequent eye checkup to eliminate the possibility of a condition called glaucoma. So that's another major cause. Then another impending one, which is at this point not a major blinding disease, but considered to be a big threat in the coming years, is diabetic retinopathy. Retinal problem secondary to diabetes mellitus. As you know, India is the capital of diabetes, second highest magnitude next to China, I think, right now. So a large percentage of them would have the eyes affected, and of the people who have the eyes affected, a large percentage of them can have problems leading to blindness unless it is detected early and treated early. And then the other problems include what are called age-related macular degeneration, which with aging population in India too, it is increasing slowly. And that should be corrected with this one. So that's the other thing. Then, of course, there are various causes of blindness in children. That's again a major problem in India. And one of the biggest things for us in the country is the congenital cataract. This, in a large percentage of such cases in our country, is because of rubella. So, because we don't have universal rubella vaccination, the kids can develop rubella cataract. So, that's the problem.
So this is in spite of us having a working functional rubella vaccine. It's just that immunization is not universal.
Yeah.
So it also now falls under the preventable category, but unfortunately we are yet to prevent it.
That's right. Yeah.
So beyond this, Dr. Rao, if I just have to take a parallel with some of the recent developments we've seen with cochlear implants and so on, where there are people who have not been able to hear perhaps for a lifetime or for a large part of their lifetime, with new implants, new technology, they're able to hear for the first time, either ever or in a long time. Are there such breakthroughs that are also happening in vision? Because one thing I keep hearing from some of my friends who work on stem cells is that with some of the stem cell technology and maybe gene editing technology, it's the first intervention where they can do something meaningful from a healthcare point of view could be in the eye. Are we talking still science that is decades away, or is this something that can make a real difference in the near future?
No, actually, before going back to children blindness, there is another important cause everybody has to be cognizant of. That's called a condition called retinopathy of prematurity. The premature babies, it is a must that every premature baby has to be screened within 30 days of its birth. Otherwise, there is a risk that these children develop a condition called retinopathy of prematurity or ROP that can make them blind. So that's an important cause, and it is increasing in number in our country. So answering your other question, stem cell biology is an exciting field. We are on the cutting edge of that in our institute. We do a lot of research in that area, both on the front part of the eye, the stem cell related to cornea work as well as retina. And I think what has happened so far is successful usage of stem cell transplantation for corneal problems. And that's been proven and is being applied all over the world now. The retinal stem cell transplantation is still in the, I would say, experimental stage and not still in routine usage clinically anywhere in the world. The other area that's happening is the artificial corneas and all that are being developed, where a human biological cornea doesn't have a chance of success because of various factors in the host eye. So that is also a field that is becoming big and growing. And one other thing similar to cochlear implant is people are now looking at retinal implants. So these are still again very few studies done on very small numbers in some centers in the US and in the UK. There is a large project going on in Australia, but very expensive. Several millions of dollars have to be invested into the research of that. Those countries are able to do it because of the funding from the governments there. The National Eye Institute in the US, for example, has an annual research budget of $750 million.
Wow.
So those are the kinds of things that they can do because it requires huge investment into that kind of thing. So that is beginning. That's what you hear occasionally in the press about the stories of these implants, retinal implants and all that.
Thank you, Dr. Rao. Before we take a break, I just want to ask you a little more about corneas. So, for example, many of us now carry small cards with us on our wallets as well, saying that we have volunteered to be an eye donor. Because
Right.
in the untimely passing of any of us, the least we can do for the people around us is if our eyes are safe, we can donate it, right? But when we're doing that donation, essentially, are we donating cornea? Is that the current part of the eye that can be of use to another person?
Actually, right now, the most commonly used tissue within the eye for transplantation is cornea. Of course, there are some other parts of the eye that can be also used, but the most common is cornea. Most common need is also for cornea. And India requires approximately 100,000 corneas of transplantable quality each year to meet our demand, but we are only around 30,000 corneas transplants a year in the country. We were the first ones now 30 years ago that started an eye bank in Hyderabad, employing international standards with the support of an American eye bank, and followed all the systems that the US developed. One of the most successful things that helped us was a program called Hospital Cornea Retrieval, placing full-time grief counselors in major hospitals, counsel the bereaved families to convince them to donate the eyes. And that way we have been very successful, and we are now one of the 3 biggest eye banks in the world, and Hyderabad has no waiting list for corneal transplants for the past 10 years. In the country, the only city with no waiting list.
And Dr. Rao, I'm not personally too familiar with what goes into this. We know that when it comes to kidney transplants and others, there has to be a lot of work that goes into whether the host and the recipient, their immunology matches and whether the body will reject it and so on. Are those concerns less important when it comes to the cornea? Is the cornea a simpler piece of tissue which is not as easily rejected by people who are receiving the implant?
Yeah, fortunately, all those tests are not required for cornea. Although corneal graft rejection can happen, But these testing and compatibilities are not required. Second thing is all corneal donations are from post-mortem eyes. It's not from a living donor.
Thank you, Dr. Rao. Let's take a quick break and come back. And I want to spend the second half of our discussion talking about healthcare, how you have seen it transform over the last few decades and what is in store for us in the coming decade.
Okay.
And before we take the break, I want to thank the Takshashila Institution and the Independent Public Spirited Media Foundation, IPSMF, for making the Pragati Podcast possible.
नमस्ते, मैं हूं सौरभ चंद्रा
और मैं प्रणय कुटस्थाने।
जब महफिल खत्म होते होते दरवाजे के बाहर पुलिया के ऊपर हम दुनिया भर की जटिल समस्याओं को सॉल्व करने में लग जाते हैं तो हो जाती है पुलियाबाजी।
अब आजकल के अपार्टमेंट वालों ने तो कभी पुलिया देखी नहीं होगी, पर आप फीलिंग तो समझ ही सकते हैं।
तो आइए शामिल हो जाइए हमारी पुलियाबाजी में, जहां प्रणय और मैं एक से एक इंटरेस्टिंग टॉपिक्स की तह तक जाएंगे।
आर्टिफिशियल इंटेलिजेंस, बिटकॉइन, पाकिस्तान, मेडिकल एजुकेशन, करेंसी क्राइसिस, कभी हम दोनों के साथ और अक्सर स्पेशल एक्सपर्ट गेस्ट की कंपनी में।
सुनिए हमें IVM की वेबसाइट, ऐप या अपने फेवरेट पॉडकास्टिंग प्लेटफॉर्म पर हर दूसरे हफ्ते।
Hi, and welcome back to the Pragati Podcast. We are here today talking to Dr. Rao about healthcare and eye care in India. Dr. Rao, first I just want to make this proposition and see if you agree with it. Today, do you think metropolitan India, that is big cities like Hyderabad, Bangalore, Delhi, Mumbai, do you think we have eye healthcare access on par with the Western world?
Yeah, I would say in terms of competence and infrastructure, major metropolitan cities have all the facilities that are available in the West, yes.
And I know that, of course, India is a much poorer country, and even within our cities, when we talk about the city, I am personally far more privileged than many others. Many of our listeners today would be far more privileged than many others who live in the same city as us. But from a cost point of view, is India's eye care more cost effective than similar interventions elsewhere, be it on whichever side of the Atlantic?
At one end of the spectrum, it is true, we are less expensive. At the higher end of the spectrum, I think we are matching some of the cost figures in the more developed countries of the world. So the only thing about the urban thing and availability of all this is availability is there, accessibility is also there. The biggest issue in urban areas is high quality care being available to less privileged people. So that's where we fall short. So in one sense, good quality eye care today in India is available to anybody because there are many not-for-profit hospitals in our country, which is a great model for the rest of the world, where anybody can go and get their eyes treated free of cost for any problem. But at the same time, there are not enough of those to take care of the entire magnitude of the problem in the country. If you look at all the medical specialties, ophthalmology and eye care are perhaps the most philanthropic of all the medical specialties. In no other medical specialty do you think of free patients. It doesn't just come. You don't even come and discuss that aspect. Whereas in eye care, it has become a common thing. Every ophthalmologist thinks of, how do I provide some free eye care?
Dr. Rao, I really want to understand that a little bit better because we'll come to the public healthcare system and eye care separately a little bit later. But why is it and how did this happen that in the private eye care industry that exists, there is still this strong philanthropic focus? How did this come about? It can't be an accident, right?
It's not an accident. It came, that's the good side of good outcome of the massive eye camps we had in the past. That eye camp culture, every trainee of ophthalmology attended eye camps, served in the eye camps. So when they become ophthalmologists, they carry that culture. So if not 100% of them, a large percentage of ophthalmologists, even when they are in private practice, continue to provide and continue to think of providing certain percentage of their time free of cost to poor people. And that's a great thing that this country has, and it's more or less a unique concept in this country. No other country do you see this. Even in sub-Saharan Africa, which has lots of problems of poverty, the concept of free eye care rarely exists.
Could you tell us a little about the history of this, Dr. Rao? I mean, you also came and set up practice here in India in the 80s. What was your journey like, and what was the journey of people who came before you and who were your compatriots from those days? What was some of the efforts that happened, and what was the ethos that people worked with?
The 3-4 generations of good ophthalmic leadership in the country that have made eye care very good today. I think the standard of eye care in India is among the best in the world, and certainly the best among the developing countries. We are ahead of everybody else. That is provided by 3 or so generations of ophthalmic leadership. In the most recent generation, the examples are the Arvind Eye Care System in Madurai. Dr. Venkateswamy established that and developed that culture of providing care to everybody was practiced very well in large volumes in that system. The second great example is Shankar Nethralaya in Chennai. Dr. Badrinath returned from the US, started Shankar Nethralaya, and with a missionary spirit of providing excellent care and combine that with being and making it available to all people. When I returned, I came back with the idea of replicating the quality of eye care that's available in the US and make it available to everybody. And we have been fortunate that it's been possible to practice that over the past 33 years. And now there are several nice examples of such things, such institutions spread throughout India. And you see it only in eye care. That's the unique feature.
So is this possible, Dr. Rao, because there is cross-subsidization involved? Is it because more doctors are, along with cross-subsidization, just donating their time to this? Because I want to understand that a lot of this will cost money, right? And somebody will have to pay for a lot of it. When we are not yet talking about the public healthcare system and the government-provided healthcare system, how does one make ends meet finally?
All factors. One is cross-subsidization. Without question, that's what we do. Half our patients don't pay anything. And the other half, we have a multi-tier paying system depending on what kind of facilities they want when they get admitted and what kind of consumables they want and all. There's some packages. So the money we generate from our paying patients cross-subsidizes our non-paying patients. The second is certainly the philanthropic aspect of both the ophthalmologists and the general philanthropy that supports eye care throughout the country. Both these factors together made the models of not-for-profit eye care in India exemplary for the rest of the world.
Here, Dr. Rao, I just want to ask, do you have an estimate of how many practicing ophthalmologists are in India, and beyond ophthalmologists, other trained specialists who might assist ophthalmologists? What kind of human resources do we have in the country versus what do you think the need in the country might be?
I think we have about, the estimate is about 20 to 25,000 ophthalmologists.
Okay.
And then about little more than that, optometrists that support the ophthalmologists. That's the human resource thing. And of course, there are other cadres of people like refractionists, opticians, etc. But these are the two main groups. That's the number. The ophthalmologist number, ideally we should have probably for our needs around 40,000 and optometrists about 100,000. So the ophthalmology has progressed much better than optometry until now, and optometry has just begun to advance in standards, number of optometry schools, etc. in the country. So together these two groups should be able to take eye care to the next level in the country.
So in that sense, the difference between the need and the existing number of professionals is perhaps closer in ophthalmology than many other practices of medicine in our country, right? Because I think one of the worst might be something like psychiatry, but in general, when we look at doctors per population and the need for them in India, the gap seems to be humongous. And the gaps you mention here seem to be still significant, but perhaps something we can address in the foreseeable future.
Yeah, our problem is not so much the number, but the maldistribution. It's the lack of availability of ophthalmologists in rural areas. That's where the most problem is. 70% of our problem is in rural areas, and we hardly have any qualified people there. The second is the non-availability of ophthalmologists in certain parts of the country, like some northern states and northeast, and even in every state in some districts. So that maldistribution is the major problem than non-availability of the specialists.
And even the initiatives you mentioned, the people you mentioned, from Arvind Eye Care, Shankar Nethralaya, all are largely from the southern states, right, including your efforts. So in that sense, as the South Indian states have developed perhaps a little more quickly than some North Indian states, some of this eye care, some of the societal evolution and private philanthropy and efforts all coming together seems to have taken shape here in the peninsula. And clearly there is some work to be done yet up north. So far we've talked about the private and philanthropic efforts. How do you see the public sector and the public healthcare system responding? How do you imagine the role of that to be? I know that you are currently either working with or advising multiple state governments, both at home in Hyderabad and in Telangana, and also with Odisha and elsewhere. I know that you've also published some papers on how you have reimagined what government plus private eye care can be. So could you tell us a little bit about that? How do we make eye care that is at the primary, secondary and tertiary levels available, that is affordable and accessible to all Indians?
I think the government of India started with the National Program for Control of Blindness in 1976. In fact, that was the first such program anywhere in the world. So there's been a commitment to blindness from the government side for a long time. And it's been investing also, starting from that World Bank loan I earlier referred to in 1991 or so. Till now, there's been a regular support from the government of India to the national program for blindness. So that is there. And I think there are 2-3 factors that has certainly helped to some degree revolutionize the quality of eye care. In the last, I would say, 1 to 2 decades, there is a significant improvement in the public eye care system because of this and because of training of government ophthalmologists and other eye care personnel. But what is required going into the future is a serious overhaul of the entire system of the governmental care and government infrastructure, training of people, faculty, etc. So that needs to be done as a big vision project. While we are doing screening camps, we're doing massive cataract surgeries and all that. But I think for the longer term strategy, we have to improve the entire system of eye care in the public sector. And the second is eye care is a great example of a very strong public-private partnership which has proven to be very successful in India. And that has to be continued and strengthened. And the true spirit of public-private partnership should be practiced. There should not be any suspicion. On the other hand, there should be trust between these sectors. And once you have that kind of collaboration, the problem of blindness in India can be taken care of.
Could you give us some examples, Dr. Rao? How is a public-private partnership, how has it been imagined in India, in any instances, including your own work?
Classic example is the cataract program. The loan is taken from the World Bank. Then after that, the government of India started investing. And out of that, number of subsidies are given to cataract surgeries to lots of not-for-profit hospitals outside the government sector. That's one example. Because of that, the volume of cataract surgery has increased significantly. The same thing is available for the training. And they also gave grants to improve the infrastructure of several of the not-for-profit hospitals in the country. So that's how the public-private partnership has happened. And in our case, I would say the government's role was in many places where we work. They have facilitated the availability of land to build our institutes and providing it at a lower cost to us. Other thing is that we have worked with them in a variety of ways in being the technical partner in these three states, Andhra Pradesh, Telangana, and Orissa, and at various stages for the past 25, 30 years. And that technical partnership involved training of people, helping to redesign the infrastructure in government hospitals, etc. So these kinds of things that can happen in other states and the rest of the country. There are a few other states that did the same thing with other groups. So these are the kinds of examples that have to be replicated in a larger scale.
Absolutely. And Dr. Rao, if I can ask, you had mentioned earlier that a lot of the primary and secondary care does not need anyone travel to a large city hospital.
Right.
So when we are talking about even in South India or in Middle India, some of the less developed and the poorer areas, be it parts of North Karnataka, parts of Vidarbha, or even if we go up north to Bihar, parts of Uttar Pradesh and so on, how do we really make this possible? Why would, say, an ophthalmologist even want to work in government as opposed to, set up a private practice or join a private clinic, even if that clinic does philanthropic work as well? How do we realign the incentives such that people can, one, start working in the government healthcare system, and two, actually be willing to work in places that are not Hyderabad or Bangalore or Chennai or Madurai?
No, that's right. That's a challenge. Getting the ophthalmologist, well-trained ophthalmologist to go and work in rural areas remains a major challenge. Even for us, it's a challenge to take them to our rural centers. But what we are doing is rotating our ophthalmologists from the big cities, because hardly anybody is willing to live permanently because of all the issues of social, other issues in the rural areas, and non-availability of schools for their kids, the environment, etc. So we have to come up with not only incentives, but we have to make the work interesting. If you make the work interesting, there are certain people who will be willing to go and work there in the rural areas, even on a short period. Even if somebody gives 3 years, we keep talking to our trainees and tell them that go and work there for a year at this stage. Then 25, 30 years later, you can look back and smile and say, yes, I did my part.
So it can be like a trial by fire for younger graduates and younger professionals.
Yeah, no. Also, there's an opportunity for them to learn about rural areas and what India really is.
And in general, even when people go to medical school, often the advice is that maybe go work at a government medical school or study at a government medical school, because the patients that you interact with and the patients who you have to help, the diversity of cases that can come your way can enrich your student experience, right? So is the case similar, that early in their career, people can learn a lot by going and working in far-flung areas?
No, these are impressionable ages. People form opinions and then strong impressions. And so some people might decide to live there forever.
Indeed. And perhaps then it also means that people who are entering the profession should also ideally come from all sections of society and from all parts of the country, right? Because if I'm a Kannada speaker from Bangalore who enters ophthalmology, I will still have some preferences even if I choose to spend a few years elsewhere.
Yeah. So I tell people in a light-hearted way, if you have lived all your life in a city, you're not an Indian.
And any parting thoughts on your side on what do you think we can realistically achieve as a country in the next, I don't know, few years or 5 years? What are realistic goals do you think India can achieve? And because we can actually sprint and get to that place, we'll have the confidence to go even further. What do you think are the big goals that we should be chasing as a country right now when it comes to eye care?
I think I'll just tell a little bit about my views on healthcare. This pandemic has certainly shocked everybody and opened our eyes. I don't know if you may have watched the TED Talk by Bill Gates a few years ago, where he said we should be investing on fighting microbes than investing in missiles, because microbes have a better chance of killing hundreds of millions of people, not missiles. And even with this pandemic, I don't see any major announcements about significant investments in healthcare.
Indeed.
And it's about time that we wake up and prevent the next pandemic, because it's going to happen whether we like it or not. So these are the kinds of things that has to happen at a big level, at a governmental level. The second thing is we have to fix our primary health care. Fix big time. Improve the quality, improve the infrastructure in those places, create proper incentives for the people to work there, etc., etc. That's a very important thing. And today, those cracks are showing with this pandemic, how poor our primary healthcare system is. Where it could be controlled very well, if you look at the world map, is where the primary healthcare system is strong. The second is we have to fix the education part, the medical education and healthcare education. So that is very, very important. And that has to be both in terms of realizing our limitations and then fix them. If we don't realize our limitations and we keep on saying we are already wonderful, this is not going to fix. So there are big problems with our medical education, and that has to be recognized and fixed. And if that is done, the aspiration of providing universal health coverage can be really accomplished. We can throw money. By throwing money, we are not going to be able to solve the problems. But somebody has to really identify the problem and take care of it.
Dr. Rao, thank you so much for your words, and thank you so much for opening our minds and teaching us so much more about eye care and the human eye as such. And thank you so much for joining me on the Pragati Podcast. It was an absolute pleasure.
Thank you. Great pleasure for me too. Thanks so much and nice meeting you.
Thank you for staying with us till the end. If you have any questions or comments, do write in to podcast@thinkpragati.com. And hey, if you like the podcast and listen to us on iTunes or Apple Podcasts, please leave us a rating and a review. It'll mean a lot to us. The Pragati Podcast is available on the IVM Podcast app and pretty much every other podcast app and platform. We are there everywhere.
Do you wish you were smarter? Well, so do we. But the next best thing?
We could make you sound smarter.
And to help you with this endeavor, we are Simplified, a podcast that attempts to break down the complex world around you with a little knowledge, a lot of poor jokes, and a ton of random trivia.
Episodes out every Monday.
On the IVM Podcast app or wherever you get your podcasts.
See ya!
Hi, my name is Anupam Gupta. I'm B50 on Twitter. I am the host of Paisa Vaisa, the show that talks money. On my show, I speak to experts from every field of money and finance, from stock markets, equities, debt funds, credit cards, life insurance, every possible area of money and finance that you can think of. We even did an episode on cryptocurrency. I've got fantastic guests from mutual funds to personal finance experts everywhere. Robo-advisory, startups, just name it, we've got it. At Paisa Vaisa, we help you make smart decisions about money. You work hard for money. Now make your money work hard for you. New episodes out every Monday, and you can listen to my show on the IVM Podcast app or any other podcasting app that you have.